welcome to YHTV's Magical Medical Tour. I'm Christina Suzama. We are at episode 21. Here with me today is our wonderful medical guide, Dr. Glenn Woolman.
And greetings to you, Christina. Welcome everyone to Magical Medical Tour. I'm Dr. Glenn Woolman. I will be your medical guide each week as we travel through the healthcare galaxy looking for optimal health. How are you doing this week, Christina?
Fantastic, with this nice cool weather that's come hit us down here in Los Angeles.
You like that, huh?
It's nice. It's nice. You know that perfect zone where you really don't have to, like, you're not like really dealing with all the desert heat or the Santa Ana winds blowing, and it's just nice between the humidity and the heat. Great balance.
I like the heat. I like the desert and the heat. How's Trinity? What's happening in the world of Trinity?
Going good. We have a lovely, Rosemary Toddclough tomorrow. She works with teachers who work with children. And,
oh, wow.
Yeah. And she created these things called yoga dots. So we have her on tomorrow. We're very excited. Anything to do with kids, the next generation, and how we're educating them and creating all the awareness and getting them moving into this life is always exciting, isn't it?
Yeah, it is exciting. And speaking about exciting, I'm introducing a new segment today. We're going into a new quadrant of the healthcare galaxy. We've been in the quadrants of normal healthcare, interviewing cardiologists and pulmonologists and infectious disease people. And we've even gone into a little bit of some variations with sleep medicine doctors and hospice doctors and addictive doctors. And we certainly have moved into the alternatives and integrative care of homeopathy and traditional Asian medicine. And a few weeks ago with Dr. Fox, chiropractic. This week, my special guest is Dr. Beth Nash. She is a true innovator. Aside from being a clinician, she also has been into healthcare publishing. She's into innovative ways of improving patient care and empowering patients. And she's doing many things that we're going to talk about today to innovate the actual healthcare practice in our world. So I would like to welcome to all of our viewers and to you, Christina, Dr. Beth Nash. Welcome, Dr. Nash.
Thank you so much.
Hello, Dr. Nash. Thank you for joining us here on the show.
Thanks for having me.
Beth, what I usually do as the medical guide is give people somewhat of a direction of where we're going to go today, and hopefully we will go through some of that path. So I always start out with having our viewers learn a little bit about your journey in terms of why you decided to become a healer, when it happened, what places you went to get to where you are today. Then we're going to look at your views of healthcare and its issues and how some of these could be fixed. And I want to look at a number of areas that you work in, including communication, patient empowerment, social media, and technology. How does that sound to you?
Sounds great.
Excellent. Why don't we start out with a little bit of your journey? Tell us about you. What brings you to the healing arts, and what do you bring special to it?
So I started out as sort of a math science nerd in high school. I was even captain of the math team. Played on the bridge team and the chess team. And I went to college and decided to study biology. I really wasn't sure what I was going to do with it. And at that time, I have to be very honest with you and say that I didn't really have any particular healing ideas, but I just thought, I could get into medical school, so I guess I'll go to medical school. And I had done a lot of basic science research, and I just sort of thought I would become a basic scientist academic. And a few things transpired to change my journey. I was studying infectious diseases It was a 3-year fellowship. I did 1 clinical year and then 2 basic science research years, and they were really basic science. And during that time, my younger brother was diagnosed with cancer, and he died in very short order. So within a few months, he was dead. And it was just as I was finishing my fellowship. And it just rocked my world, obviously, but also I got to see our healthcare system from the patient perspective, and it really wasn't very pretty. So here was this 28-year-old kid who was dying and really being treated terribly, really almost ignored by his healthcare providers because there was nothing they could do for him. So that was number one. Number two was that my brother literally died around the time I finished my fellowship and started my first job. So we mentioned that I was an infectious diseases doctor. Well, I went into infectious diseases because I liked the scientific idea of making a diagnosis and curing the infection. Unfortunately, the AIDS epidemic had just started. So I went from treating people who I could make better to people who were chronically ill and, had at that time almost a certain death sentence. And so that's when I learned that there's a lot more to healing than curing the patient, that healing is a whole different thing. So from then on, I have to say, there were two things that motivated me. One was life is short, take risk, and the other was find a way to improve the healthcare system and the way that patients are treated.
Yeah, and that's been your life journey, and thank you for sharing some of those very personal things with us. So let's continue on your journey a little bit. And you moved from infectious disease. Where did you go from there?
Yeah, so I spent about 7 or 8 years actually as an infectious diseases specialist, and it was really my dream job, I have to say. It was phenomenal. I learned a tremendous amount, and as I said, AIDS was really one of the best learning experiences for me because, again, I really learned that you can heal without making the person physically better. And I also learned about team-based care. So with AIDS patients, it wasn't just one doctor and a patient, but you needed the nutritionist and the physical therapist, and so we really introduced team-based care. It was a phenomenal experience. The other thing that I learned as an infectious diseases doctor, and I'm sorry to dwell on this so much, but I really feel that it was a key pivotal moment for me, is in my outpatient practice in infectious diseases. I was seeing these patients who nobody else knew what to do with, and they would have all these vague symptoms and nobody could figure it out. And what I came to realize was that what these people needed was for somebody to listen to them. And to, other practitioners were just giving them lots of tests and trying to get rid of them. And many of them had really social problems that I think were influencing their health. And so that introduced me to the whole notion of the mind-body connection and how your mental state can really influence your physical health. So I knew I was going to do something different. The next thing I did will sound a little strange, but I spent 3 years as a managed care medical director. And that was sort of my on-the-job MBA. I really learned about quality and improving processes. And it was also a very, very informative, although not exactly healing kind of experience. And from there, I actually took a job at a startup. It was an online service exclusively for doctors, where doctors could actually talk to each other in bulletin board like discussion groups. This is actually pre-World Wide Web, I should tell you, sort of in the 80s and 90s. Sorry, that was the 90s, middle 90s. And what I saw was that doctors were collaborating with each other and actually solving their clinical problems across the country. So a doctor in the middle of nowhere could get help with a case by communicating with other doctors online. And I can't even begin to explain to you how eye-opening this was. It was like a eureka moment, like, oh my God, technology can really help to improve care. The other thing that doctors were able to do online actually was to talk about their own problems with difficult patients, problems with substance abuse, problems with HIV infection themselves. It was a safe, secure, doctor-only environment. I don't think that makes sense today, but again, it opened my eyes up to how healing could happen, even in the online, not face-to-face world.
Yeah, that's very innovative in itself. Patients are always worrying about second opinions, but behind the scenes, doctors are asking other doctors and going online and communicating with each other all the time. You're getting second opinions even if you don't know you're getting second opinions in many cases. Don't you find that?
Absolutely. And when I was in clinical practice, we used to do the so-called curbside consults where, you'd run into a colleague in the hallway and say, oh, I'm glad I ran into you. I have this patient, blah, blah, blah. What do you think? And I think there's a lot of that in medicine. And I think bringing that online just enhances it.
Mm-hmm. You then went into the publishing world and healthcare.
I did. So it all maybe sounds a little strange, but I think the common thread that you'll see is it is about healing and it is about communication. So I took a job at the BMJ Publishing Group. It used to be called the British Medical Journal. It's one of the top 5 general medicine journals in the world. And they're very innovative, and they were doing some really interesting things. So what they wanted me to do was to help them create a website for patients that would help patients understand their chronic medical problems. So what my job was to take very complicated medical information and really translate it into patient-friendly language. And it was a real learning curve for me because using lay language to explain complicated things really can be done. But some doctors, and myself included at the beginning, find it frustrating because it's not exactly correct. So you can't, you have to kind of make it understandable, and then you might lose a tiny bit of the science, but it doesn't really matter as long as you're getting the information across. I think the other thing that I learned was really, what is evidence-based medicine? I didn't really understand what it was. I thought that evidence-based medicine was reading the literature and then doing what the literature says. Well, what I learned and what I came to really embrace is that what evidence-based medicine is looking at the totality of the available research evidence and then using it to make a clinical decision in concert with 2 other incredibly important pieces. So the first important piece is the knowledge and expertise of the doctor. And the second more important piece is the values and the preferences of the patient. So what I came to learn is that in most clinical situations, there is no one single right answer. And the right answer is the answer that is best for the patient. So one really great example that I did a lot of writing about in my BMJ days was prostate cancer. Where there are 3 different approaches to somebody with prostate cancer. One is to do watchful waiting, do nothing, just follow the patient and see what happens. The second is to do radical surgery, and the third is to do radiation. And the truth is that the outcomes are not really different. But different people will make different decisions. So one person will say, I don't want that cancer in my body. I have to get it out. Another person will say, I don't want any interventions if I don't need them. So, and then some people say, well, radiation maybe is the middle of the road. But anyway, you really have to explore what kind of person you are. And that has to be in dialogue with your doctor. So what we were doing was really putting the patient in a position to understand the clinical decisions so that they could work with their doctor to make the right one for them.
Excellent. You do have a common thread. It's not just about healing. It's about looking at systems and analyzing systems and trying to figure out ways to improve the systems also. You then came back here. You worked for another magazine. Can we talk about that?
Yeah. So I spent about 8 years at the BMJ, and then I spent a little over a year at Consumer Reports. And some of the content I had developed at the BMJ was being used at Consumer Reports. And so what I was responsible for at Consumer Reports was working on their health strategy and figuring out other ways to empower patients to make the right health decisions for them. And so we went beyond just the medical information that I had already created at the BMJ, but also to start looking at how do you pick a hospital? How do you pick a doctor? How do you pick a drug? Can you take a generic drug? How does it compare to a brand name drug? And all of those sorts of questions. Ultimately, I left Consumer Reports because I just had so many interests. I wanted to pursue them in a consulting arrangement so that I could really delve into lots of different areas. And so what I've become really interested in the past couple of years is technology. And I want to try to explain that because it's a little bit confusing. On the one hand, I think technology has caused a rift in the doctor-patient relationship. So I think there's a lot of negatives about technology. Doctors aren't looking at you, they're looking at the computer, you're getting too many tests. I think technology in many ways has done more harm than good. But I think there are a whole host of ways that technology can do the kinds of things I saw at the dial-up online service for physicians, namely to enhance relationships. So let me give you a couple of examples. And some of this is work that I'm doing, some of this is work that others are doing. But let's take online patient discussion groups. So let's say there's a patient with a chronic medical condition who lives in Alaska. The doctor may have never seen a patient who's got the particular problems that patient has, but there are patients all over the world who may be very similar. So patients can go into online discussion groups and find other people who share some of their symptoms, who have some coping strategies. There's a whole lot you can learn from another patient that your doctor really doesn't know about because your doctor doesn't necessarily have that condition.
That's true.
So I'll give you one personal example. I had a very dear friend who died of metastatic breast cancer. And in her online discussion group, she actually learned about a particular blood test that she could get that might allow her to get into a clinical trial for a particular drug that had some promise. And as a result of that interaction with another patient, she actually got a treatment that helped to prolong her life that her doctor didn't even know about. So that's one example of where technology can be incredibly useful and not interfere with the doctor-patient, professional-patient relationship, but rather enhance it. Another area that's really interesting to me are sensors, both on the body and in the house. So let's say you're a diabetic and you have an automatic sensor that tells you what your blood sugar is all day long. You, the patient, get a very good idea about what things you eat, what things you do influence your blood sugar and can allow you to regulate your own blood sugar better than any sort of prescription the doctor gives you based on, a guess.
Beth,
Yes.
you're talking about, people that are diabetics now take their blood sugars. You're talking about a different type of sensor that
So
might
I'm
be.
talking. Mhm.
Tell us what you're.
Yeah. So instead of pricking your finger, a few times a day, what if you had an implantable uh, device that just fit over your finger that continuously recorded your blood sugar? And these devices actually exist and are in testing right now. So the bottom line is, I think we patients, and I use the word patient, it doesn't bother me. We're all patients. We patients know our own bodies better than any doctor knows our body, right? And so I think that there are, that we're in a better position to monitor our own bodies and make appropriate healthcare decisions based on what we find.
Hmm. Yeah, I agree with that. And to some degree, I mean, we know our bodies. We don't necessarily know what the pathology is, but we know this hurts, or this doesn't feel right, or something like that.
It's about partnership, I believe.
Right.
So, and a dialogue between the doctor and the patient. And I think doctors really need to change and really understand the value of listening to the patient. So there's actually a very famous piece written, I think, in the 1920s by Francis Peabody that says the key. I'm paraphrasing, but the key to caring for the patient is to care for the patient, right? The doctor really needs to care and want to hear what the patient has to say and not dismiss it. And so there really is this whole piece of dialogue. So I understand that on the one hand, I'm talking about sort of simple relationship things and going back to an earlier day. And on the other hand, I'm looking at technology and saying, how can that help us to actually, communicate even better?
We look at the World Health Organization, and a number of studies come out ranking countries around the world. And as Americans, we always want to believe that we're number one in things, and we're clearly not. We're, I think, 37th in healthcare in one area and 14th in another area, which is not very good. But when I'm practicing and I'm working with clients and with other physicians, it always seems like the care is good. And I'm not always sure of the statistics, although there is validity to certain parts of it. So what do you see in our system that's broken? And what do you see that's good right now?
So obviously, technologically, in terms of technical advances, we're way ahead of the game. But in terms of the care, the hands-on care of the patient, I think we're doing a very poor job. So, I think what's happened is we've gotten into this bad situation where we're over-testing, we're worried about litigation, and so we're doing just way too many tests. Then we're finding problems, then we're chasing those problems, then we're causing problems in the work.
Oh my gosh.
That are really incidental findings. And, I think that doctors feel really worried that they're going to get sued. And so instead of thinking about the patient, they're thinking, they're worrying about what they need to do to avoid litigation. I mean, I think it's gotten really bad. And I just want to be really clear. I'm not a doctor hater. I love doctors. I think most doctors go into the field with all of the right feelings, actually better than me, right? Because I already told you I went in as a science nerd. But I do think that that most doctors want to do the right thing. I think there are some things within the system that prevent them from doing that. I'll give you, another problem is just that doctors have, they're under constraints to see, a patient every 6, 7, 10 minutes. And so when you feel under the gun, I think it's very hard to do everything you think is right. It's a lot easier to write a prescription for an antibiotic than to explain to the person why they really don't need the antibiotic. And so that's caused harm because now we've bred germs that are resistant to antibiotics because of the overuse of antibiotics. So I think those are among the things that have led to the decay really in our system.
Wow, isn't that amazing? I mean, if you don't mind, I hear from both ends where I hear the technology with some doctors. They really sort of despise it because people are finding so much online now that they come into the office and it's like an hour discussion because they've had this whole list that they want to go through. And then on the other hand, I hear a lot of, I've been speaking to some young doctors in residence right now, and they're excited about it because they're excited to say, wow, it's great because these patients are coming in, with this list, and it sort of opens up all these other doors that could be for that individual. I mean, so it's like this incredible balance that everyone's trying to find right now.
Here's what I think is the problem. So yes, doctors feel burdened by patients coming in with what we call reams of paper, that they've gotten off of the internet. But part of the problem is that the reams of paper don't fit into the standard doctor-patient relationship the way we know it. We need to rethink the doctor-patient relationship. Maybe the doctor and the patient do a lot of stuff offline before they even meet face-to-face. Mm-hmm. Maybe the doctor actually prescribes information for the patient to read that they know is trustworthy in advance of that interaction. Maybe the patient actually looks at that information in the doctor's office while they're waiting. I mean, I think there's a lot of ways to rethink it. So yes, I think technology, when you try to sort of move it into the existing doctor-patient relationship, doesn't work. But we need to open our minds to sort of rethinking. So I'll give you another example about rethinking. So we take these elderly patients, in their 80s, and we tell them to come in and see the doctor once every month or whatever. Well, getting an elderly wheelchair-bound patient in to see the doctor is impossible. And then they have to wait, and then there are all kinds of other problems, and there's paperwork to fill out, whatever. And the meeting, and the patient is hungry, tired, whatever. The interaction does not go well. What if that elderly patient, didn't actually come in at all? What if it were a Skype interview? What if there were sensors in the house that determined how well the patient was doing? Maybe it's taking the patient longer to answer the telephone than it used to do. That may be an early warning sign that the patient is not as mobile as they were previously. So I think that we need to think way outside the box and think creatively.
I love that idea of Skyping with patients. I really do. We were, I had an uncle in his 90s who was supposed to die within a certain period. Anyways, we took him into our home. We wanted him to die in our home. And the beauty of the Skype was he was able to see people very, very dear to him from distances, people he hadn't seen for 10 to 15 years. And, it was, the connection was still there. He could still understand the questions that were asked. And how interesting that you bring up doctor and patient Skyping, because that would save both parties so much time.
Now, that said, I actually believe in the laying on of hands. I really think that can be really therapeutic. There's nothing like being in the same room with another person. But if you're not using the time to lay on hands and to really connect, then it's really not doing anything. So, do all that other stuff through Skype and handle all the paperwork and everything else in the non-face-to-face kind of situation. There's other ways of thinking creatively about the doctor-patient visit. What if, and this is being done, a group of patients with diabetes came in to see their doctor all at the same time? They could have a 5-minute one-on-one with the doctor, but then lots of the stuff is communicated in a group setting. And then one person can say, oh, I tried such and such, and, and this worked for me. And, so you could learn from each other. I think the value of learning from patients, other patients, I can't stress it enough. So important. And we need to find ways to really mine that rich material.
Mm-hmm.
Brilliant. The healthcare system itself has many facets to it. There's legalities and there's financial parts. There's responsiveness to a healthcare system. But from the medical point of view, from the doctor point of view, I think it really starts with what doctors or what medical students are being chosen to get into medical school. And those are the ones that come out and become the doctors that take care of a culture for a time period. What areas are you looking into in the process of choosing medical students, for example? Yeah. Can we improve on getting doctors that are more passionate or creative rather than something or someone that may be just more brilliant?
Mm-hmm. So this is an area that's really, really interesting to me because it gets to the root cause of the problem. So some people, I think, they're very smart, but not really meant to be physicians. It's not really the best fit for them. So how do we determine who's actually going to be a good doctor in the admissions process? So right now, the admissions process looks at, your grades and your boards, but that really does not predict how well you're going to do in clinical medicine. So what we do is an interview. And we try to get at, who's caring, who is a people person, who can communicate well. And what we've learned is, and there's data to support this, that an interview doesn't predict either how well somebody's going to perform as a clinician. So we've got a system where we're not really selecting for that very important piece of being a clinician. So there's a new system that we're experimenting with, which is called the MMI, or multi-mini interview, where you actually, instead of having one interview at a medical school, you have 7, 8, or 10 interviews, and they're all very short, less than 10 minutes, and each person has the exact same scenario to read for each station. So in other words, let's say there'll be 10 stations and you spend 6 minutes on each station. Each station is identical. There's a scenario that you read and you talk about, and you don't know about it in advance. Mm-hmm. And the same interviewer mans that station. So the same person is evaluating everybody who comes through and comparing them to each other. And what you're looking for is, how well does this person reason? How well does this person think on their feet? How well does this person communicate? How well does this person recover if they're nervous and they don't know what to do in this situation? And all of these situations are designed to really select for the things we're looking for in our doctors.
Is it working anywhere? Is it actually happening, or is still this theoretical physics?
It is. So the system was developed at McMaster University in Canada, and they have some preliminary data that is really quite positive. Really does look like they're able to predict who is going to be perform better clinically. And there are a handful of medical schools in this country that are experimenting with this system. Needless to say, students are not really embracing this because it's scary. And you used to be able to predict, oh, I'm going to be asked, why do you want to be a doctor? Tell me about, the hardest thing you've ever done. It was very predictable. And now, of course, you go in there and you can't even prepare. And oh, by the way, these stations, there's no right answers. So how you reason through it, how you deal with it, so.
Well, you know what? I mean, it is so funny because on this end, some of us are chuckling away here because it's exactly what actors have to walk into. You're set in a scenario where you have to improvise immediately and under the nervous tension, and you're being judged. It is an interview, but you don't know what's coming next. You don't know the next question. And that's great, I think.
I remember during my interview, one of the questions was, why do you want to be a doctor? And at that time, I was thinking about being a surgeon. And I said, well, I love to use my hands. And the admission person looked at me and said, have you thought of becoming a mechanic? So I said, no, that's why I'm here. Beth, Christina, did you want to bring something up?
Yeah, because I'm so glad you brought up the actor thing. One of the other things is, okay, so even if you select the right people, you have to train them the right way too. So just as medical education has to change too, right? Because we want to teach doctors, we get the right person, but now we got to teach them to listen to the patient. Mm-hmm. To teach them about shared decision making, teach them about, patients' values and preferences. And so one of the ways to do that is actually to bring professional actors into medical schools.
Yes.
And to tell them, give the actor a scenario and just go with it. While you're working with a student and, in one of these rooms that you can observe how the student is doing. And it's scary again for the students, but, I think will help with communication skills, thinking on your feet, and all the things that we're looking for.
Oh, absolutely. Absolutely. I mean, there is a wonderful training technique that actors use, which is a base of what an individual called Viola Spolin, and it's theater games. And in 3 months worth of these games, so it's not studying of scripts or anything like that, you really learn to listen. You learn body language, you learn full communication, which is amazing how this woman had put all those pieces together with the psychology, etc. But it works across the board. It's not just about actors, because we all act every day in life. That's what I keep saying. But it's so interesting what you're saying about the communication, because as we know, we've all run into those people who really cannot communicate, and you sit on the other side and go, am I supposed to trust you?
Exactly.
Yeah, it's interesting.
So I actually have a daughter who's an actress, and or studying acting. And whenever people look at me like, oh my God, how can you stand it? She's not going to find work, whatever. What I say is, I think that acting prepares you for anything you're going to do in life, because it teaches you how to work on a team. It teaches you, how to communicate, and it teaches you how to, deal with a situation that you didn't expect.
Yes. So, yes. It's not as glamorous as people think it is. It is one of the hardest businesses in life.
Preparation for life, I think.
Yes. Wonderful.
I think there's going to be hopefully a lot of changes in the medical school curricula, and we've been watching it for years, how hard it is. Had to have some knowledge of the integrative programs that are the integrative healing systems that are out there should be part of medical school, more nutrition. I even believe that at some point, something that you and I do as medical guides will become an actual specialty in the future. It's too complex now to just be able to deal with it completely on your own. Christina mentioned before about her uncle, and all of us deal with patients, family members, friends, relatives that are coming to end of life. What are your thoughts on how we're going to change the view of end of life, how technologies will come into play? What's new and innovative in end of life care? We did,
Mhm.
just to let you know, we did a session with Dr. Bordovsky, Michael Bordovsky, who talked about hospice, and we had a very nice discussion about hospice and palliative care. But what are your thoughts?
Okay, so so this is a really really important area and one that I feel passionately about. And in this arena, I'm going to sort of talk more about communication. So the first and foremost problem is that we don't talk about how we want to die. Death is a part of life, and I think we really need to get over this fear of death and death being the enemy. So I think that, sometimes we keep people alive who really do not have any
Mm.
quality of life, and we really need to think about that. And most people, when you ask them, they want to die at home, and yet most people die in the hospital.
Mhm.
So it's really important to have those conversations. So to me, that is the really most important thing. So we should be having these conversations when we're well. And I know it's really hard, but when are we together? We're together at Thanksgiving and other holidays. We should be open and talking about these things. It's incredibly difficult to do, but incredibly valuable. So I dealt this past November with my father's death. So I'm going to tell you the story because people look at me like I'm a little crazy, but here we go.
No one's going
Um,
to be looking at you here. It's just Christina and I.
so my father was relatively well. He was 85. He had a bunch of things that were wrong with him. But his health was just sort of slowly going downhill, and he really was unable to ambulate the way he would like. And he just sort of was failing, and he really wasn't happy with his quality of life. He got pneumonia, and he really was laid low. And what my mother and I decided to do, based on conversations with my father in advance of this all happening, was that we actually took him home. We did not go to the hospital and get intravenous antibiotics and, where he would have become confused, fallen out of bed, broken his hip, gotten a urinary tract infection, and, all those bad things that happen to elderly people in the hospital.
Mhm.
We took him home on oral antibiotics, and we got hospice involved. And I have to tell you, it was a beautiful thing. It was a very brave thing because I think, modern medicine could have prolonged his life for a few more weeks, maybe even a few more months, but it was not the quality of life that he would have enjoyed. And we used to talk about pneumonia as being the old man's friend. And I think in this particular case, it really was. So my father was able to die at home, surrounded by his family.
Mm.
So I think it's about having the conversation and having the conversation when you're well. And we're too afraid of death to do that.
Mhm. Mhm. Yeah, I agree with that. I love working with the elderly people. I call them our elders, and it's elder wisdom. And so many of them say the same thing. It's like when I tell people that I've been working with my mother for the last 5 years to help her feel more comfortable about her transition, that she can choose the time when she'd like to transition. It's a difficult balance. People say, "Well, do you want her to go that quick?" It's like, no, I would like her to see her go peacefully,
Right.
completely confident that this is just a part of life and it is a transitional process. And it's very beautiful. I always say it's, they call me like a death doula, basically, where,
Hmm.
working with the elderly or working with people who are in that position. It is a beautiful transition, and it is creating
Yes.
that awareness and that sense of confidence in everyone around. Um, I so far in my experience, the elderly um, tend to be a little more at ease with the transitions that they have to make. It's the family that's around them. That's the difficult part. I always find
Right.
is like they're the ones who refuse to let go. They're the ones who want all the extreme measures to be taken place, right? So,
I agree, but I think what ends up happening is you end up with an elderly person in the hospital, on a respirator, on a ventilator,
mm,
completely comatose, not knowing what's going on. And I think that what families need to realize is that that is even more painful
mm,
to watch. And they may even be in the situation where they have to decide whether to remove life support.
mhm.
And that's, so I think we need to think things through, and it's very hard for us to do in our culture, I think.
Mm.
Taking that a step further and bringing it more personally, Beth, at the beginning, you mentioned your brother
Mhm.
passing away at an early age. And when we talk of end of life, immediately you picture somebody who's elderly and at end of life. But there are young people at end of life also. Anything in that area that you look at using technologies or patient empowerment or social media to work with families there?
Yeah. Yeah. So, first of all, in the social media arena, there's a lot going on, actually, even for the elderly. So, when I left my last sort of real job in a real building, I did so. One of the things that that pushed me to do that was I had a very dear lifelong friend who was dying, as I mentioned before, of metastatic breast cancer. So there were a number of things that we were able to do using social media. So first of all, we used social media to arrange helpers for her. So I arranged all kinds of volunteers to take her to doctor's appointments, bring dinners, and that sort of
Mm.
thing. And you can also use social media to update lots of people about your condition. And I think that can be incredibly therapeutic for somebody, who's facing the end of life when they're really angry about it and really thinking about all the people that they're going to miss. Um, but I think, the most important thing, even for a young person, is really coming to terms with the fact that they're dying, and we don't talk about it. Doctors don't talk about it. And in my brother's situation, he actually had a doctor who was not talking to him about it. And my husband and I brought him from New York to Massachusetts, where we were in our training, to go to a doctor we knew would talk to him about it and would be able to say to him, you know what, David, it's time to start thinking about saying your goodbyes to people. And we need to be able to do that. Doctors don't know how to do that at all, feel incredibly uncomfortable with it, but really, really important, even more important, I think, with a young person than
Mm.
with the elderly who know, really tend to know when it's the end.
Mm.
Do you have any websites or places that you would recommend people to go if you were talking about social media? Anything like that?
Well, yeah. So one of the websites that helps you to coordinate the care among caregivers is called Lotsa Helping Hands, LOTSA Helping Hands, and I've used that with three different friends who have had medical problems to again coordinate the care. And then there are a whole host of there are just hundreds and thousands of websites that uh, allow you to communicate with other people in your condition or other caregivers, so there's not one in particular, but there are all you have to do is Google them and you'll find tons of them. Many of them are, completely open to the public.
From your point of view, when we were in medical school, one of the things, and through all of our training, we learned to read literature. You were at the British Journal. We read things, but we're able to discern that this is a good study, not a good study. People on the internet can read anything now. How do you suggest that they teach themselves or learn how to discern that
Mm-hmm.
something they're reading is appropriate rather than going off in tangents? Just because
Mm-hmm.
there's a group that's talking about it doesn't mean it's necessarily great information all the time.
Absolutely. So, first of all, let me say, Glenn, that I think that we doctors are not as good at discerning the literature as we think that we are. And part of the problem is that there's just too much of it, to even look at. So I could look at one study and possibly, give you a nice critique about it, but there may be 20 other studies that say the opposite. And I may not have put my hands on those. So I think that what we need to do is to all of us, doctors and patients, to be able to find sites that are doing the hard work for us and that are credible. So how do you know if a site is credible? Well, first of all, rules of thumb, .govs and .edus tend to be more credible than the standard .coms, but obviously there are exceptions. One thing I used to do, I know I've done a lot of different things, but one of the things I used to do a lot of work on is ethics on the internet. And one of the things that a credible website should have is an About Us page where they really talk about who they are, how they create their material. And it's really important to look at that and see who these people are. Oftentimes, it'll be a thinly veiled drug company website, that's just trying to push a drug or, something like that, some hidden agenda. So very important and very, very difficult.
Each week I ask our guest if they have a special health tip based on their own experience in life that they would like to share with our viewers. Do you have something you would like to share with us today?
I do, and it's
Oh, good.
It's very simple. My health tip is ask lots of questions. And again, it sounds really almost naive, but so true. If you don't understand what your doctor is saying, you cannot leave that office. You need to understand exactly what's going on. You need to have all of your questions asked. And if your doctor doesn't want to answer your questions, you need to find a new doctor. It's that relationship, I think, is incredibly important. One of the pieces of work I did a while back was on prescription drug labeling, right? Like just how that jar, that little vial gets labeled. Well, you can't imagine how many different ways people can interpret, take one pill a day. Do I take it at night? Do I take it in the morning? Do I take it with food, without food? Ask. You have to own your own health and ask questions. And similarly, the doctor has to listen in order for there to be an optimal healing relationship. So, if one of the key reasons to ask is to make sure that your questions are going to be answered, because if they're not, it really is time to move on to a new practitioner. And that could be, it doesn't have to be a doctor. It can be a yoga instructor or, a nutritionist. If you're not feeling that you can ask questions and that it's a give and take relationship, it's time to move on.
That's a great health tip. And we found through our 20 other episodes that sometimes the health tip, the simpler it is, the more sense it makes.
But that's life, isn't it?
Yeah, that's very good. There's so many things we're bringing up, and I think we could go off in many tangents for every one of the things you've talked about
today, and hopefully we can have you on again. But I wanted to ask you and give you an opportunity. Is there anything that we did not bring up today that you are interested in putting out to our viewers?
Yeah, I guess what I'd really like to do is it's sort of reiterating something that I already said, but I think that, and it gets back to something you asked about earlier. I think the most important thing in the healing relationship is, again, for the doctors to listen. So there was recently a case here in New York. I don't know if you guys heard of it. It's a horrible story of a young boy, I think about 12 years old, dying of sepsis. And it's horrific. It is just horrible, horrible, horrible. But
sepsis, for everybody listening, is an overwhelming infection in the body.
exactly. So what happened to this kid? What had a little scratch on his knee from, or somewhere on his body from playing baseball. Then he developed other symptoms and some fever, and people just assumed he had a virus on top of this, this little injury. And long story short is the family kept saying over and over again, no, it's not a virus. There's something else going on here. And the doctors just sort of said, it is, it's going around. We've seen it. And long story short, the family wasn't listened to. And I think that that's the take home message from that case. Most people are talking about, oh, we need better ways of detecting sepsis, and, we need to check the labs better and do all these other things. And again, I'm going to go back to the simplistic and say that, again, for me, the key thing that's broken in our healthcare system is communication, and for patients to speak up and for doctors and other practitioners to listen.
So I have a question on that. To be able to diagnose the sepsis, what would have had to be done? Like a blood test or, a swab? What would it have taken?
Mm-hmm. So in that particular case, there was a problem, which was, so here are the ways that the sepsis could have been detected. One is that your white blood cell count in your blood goes way, way up, because when you're fighting infection, your body makes extra white blood cells. Mm-hmm. Well, in this particular case, his white blood cells were elevated, but nobody checked. Second thing is when you have sepsis, overwhelming infection, your blood pressure may be getting too low and your heart rate may be getting too fast. Well, that was happening in this child also. But again, people were fixated on what they thought the diagnosis was, and so they weren't looking at all of the data in front of them, sort of jumping to conclusions. So there were some very simple things that would have detected this, but I'm going to call that a communication problem too, because the tests were done, they just weren't looked at and reacted to.
Oh, so the tests were done.
They were.
Wow.
Yeah. But again, everyone just had in their mind what the diagnosis was and send them home. It's a virus. Send them home. Mm-hmm. So, yes.
How often do we hear that happening?
Yeah. I think it happens more often than we would like. I think that medical care has gotten very complicated. It's very hard to keep track of all the different blood tests and other tests. And, I think things sadly, and then there are handoffs from specialist to specialist to specialist. And I think things get lost in the shuffle. And I think the patient is left to be their own case manager, which is why we need medical guides to help us through the process, because I think it's really not fair or possible really for the patient to manage all the different pieces and pull them all together.
When they're trying to get well at the same time, right?
Yeah, exactly.
Yeah.
Again, it does go back to what you said. We know our bodies and our family know best. And I think that if we kind of summarize and review what you're doing, Beth, is you're looking at communication as a very important part of doctor-patient relationships and patient empowerment. You're putting technologies together. And so for me, at least, even though we may have some parts of our system that are broken, I feel that because there are people like you out there who are innovators and not just thinking about it at your house, but you're going to medical schools, you're going to publishing places, you're working with communities, you're doing so many things. It does give hope to all of us that the future of medicine has some light in it.
Yeah, and I think that there is a very bright future We just need to get stuck out of our rut and, start thinking creatively, because there are so many innovative things to do at our fingertips.
And I think on that note, leaving on a bright future, I would like to say that I'm very grateful to our special guest, Dr. Beth Nash, for sharing her wisdom and expertise with us today. I want to thank all of my healers and my teachers, and I look forward to being with Christina as we go on another journey into the healthcare galaxy next week. But until that time, I wish you all optimal health. Thank you so much, Dr. Beth Nash.
Thank you, Dr. Nash. And thank you, Dr. Woolman, our medical guide. As per usual, another wonderful, wonderful show. I'd like to remind our viewers and thank our viewers for joining us today. Don't forget, every Tuesday, it is our Magical Medical Tour with Dr. Glenn Woolman, and every Wednesday is Trinity of Life, both here on yogahub.tv. And just to let you know, the video replays are loaded up right after the show. And for those of you, we have started our podcast. So you can find us through the iTunes directory and just search for yogahub.com or YHTV. And you can stream the first few shows. I do believe the first 6 shows of Magical Medical Tour now. So we're very excited to present that to you. I just want to remind everyone, you can also find Dr. Glenn Woolman at myyogahub.com/G Woolman. And on Twitter, his handle is at Glenn Woolman. That's pretty easy. And of course, you can find him directly and contact him directly through his own website, glennwoolman.com. And thank you very much for joining us today. And we look forward to seeing you tomorrow, which is Wednesday, and again next Tuesday. Take care and namaste. Have a wonderful week.